because you share no similar genes. If there's a first-degree relative with the disease, the chances go up to 10 to 20%. And interestingly, in identical twin pairs, the concordance is 55%. So there is, again, a very large environmental or other component to this disease in those patients who have 100% similar genes. So several years ago, the National Alopecia Areata Registry was started to better understand this disease, to find treatments and a cure. And the registry principal investigators range from Dr. Cristiano and the New York City group at Columbia to Dr. Norris, holding his hand up there, from the University of Colorado, Dr. Price from the University of California, San Francisco, myself, and the principal investigator, Dr. Madeline Duvek from Houston. This registry provided over 1,000 cases for research purposes, and the expert team at Columbia, Dr. Cristiano and her team, identified 8 genes that contribute to this disease. And these genes, as we saw in the vitiligo slide, these genes, like in that picture, also associate with type 1 diabetes, as well as rheumatoid arthritis and celiac disease. All autoimmune diseases with pre-existing treatments. In this complicated slide, just focus on the results of the GWAS studies that were published in 2010, where the immune system genes were implicated and specific hair follicle genes. But what stood out was ULBP3, the cytomegalovirus UL16 binding protein on chromosome 6q25.1. And these genes make this NKG2D activating ligand or signal. One then turned to look at scalp biopsies, and scalp biopsies now are part of the registry work to see whether these genes were turned on or expressed in the scalp, and higher levels of ULBP3 were expressed during active alopecia areata. And you can find this picture if you Google alopecia areata, it's out there. So the danger signals are there. The normal person has, on the top panel, very little red. In alopecia areata patients, you see a lot of red. And this was correlated to, say, honey on the follicle that brings in the bees, and hence that picture of the bees in the flower. Then what happened is people began to realize that cytokines were important, ULBP3 was important, and that there were these drugs, these biologic agents out there that could target the pathway. So instead of using prednisone and shutting down everything, one could become a little bit more targeted. And the JAK family of tyrosine kinases rose to the surface, as was noted also in vitiligo. And the first ones that were looked at were ruxolitinib, which in the United States costs about $10,000 per month, and tofacitinib, when given orally, costs $2,000 a month. But despite all that, the Columbia University group went on to look at ruxolitinib given orally as a JAK inhibitor, and it reported the improvement in hair regrowth. These are examples of 2 patients. And as the work has gone on, there's a large cohort of patients at Yale, a large cohort of patients at Stanford that are on these oral medications with reports of improved hair growth. And the more that patients are treated, it's clear this is still an autoimmune disease, that if you stop it, there's a chance of this disease coming back. So where the world is going is to try to look at topical products, and right now there is a study sponsored by a company called Insight. It's a topical formulation of ruxolitinib to treat alopecia areata, and it's under development not only for alopecia areata, but also psoriasis, atopic dermatitis, and other autoimmune diseases. And this study is currently well underway. The company is finding a signal, so they are going to be expanding the number of patients. And at the gut level, this is the start of a new era. There will be the next group and the next group of medications that will be improved and safer and better. I'd like, if I still have time, to turn to androgenetic alopecia briefly. We all know the treatments: topical minoxidil, oral finasteride, hair transplantation, combination treatment, and anti-androgens for women with hair thinning with or without systemic evidence for androgen excess. PRP, microneedling, all sorts of things are out there. But what has come to be quite popular is to use low-level laser light or photomodulation. We also have now in clinical trials cortexalone 17-alpha propionate solution. This is a steroidal anti-androgen that is being studied for the topical treatment of male pattern baldness. Allergan has started a study on a medication, an oral medication, which affects the prostaglandin D2 pathway based on the reports of the Cotzarelis group from Penn. And then the Wnt pathway, again, enters into discussion, and there is a topical solution that activates the Wnt pathway that has recently completed clinical trials. So photomodulation. So complicated, because when the laser comb first came out, we all thought this is a joke. But then the company decided they would do a trial and suggested that the University of Miami, Cleveland Clinic, and our university be engaged. And they made a sham device as well for this study. And when the study ended, we all realized that light does do something to hair and hair growth. And we already know as dermatologists that that's true. We see paradoxical hair growth sometimes after laser hair removal. We may see increased hair growth in patients with porphyria. So although we don't understand what light does, it is postulated that low-level laser light acts through oxidative metabolism and transcription factor stimulation. So in the US, this first device was approved. The wavelengths range from 650 nanometers to 678 nanometers. So it is in the visible spectrum, as shown on this slide. And then these devices proliferated. So when you fly on an airplane and you pull the magazine out, you can buy this one and that one. And there are studies in the literature supporting all these devices. So colleagues went ahead to look, at least in the US, what has been cleared as a device by our Food and Drug Administration. 14 devices have been identified. They cost from the simple laser comb $195 to $3,000. The shapes vary. There are combs and bands, helmets, caps, hats. They all have laser diode quantities ranging from 7 diodes to 272 diodes that are light emitting. And treatment frequencies are recommended 2 to 4 times per week. So patients ask, will I do better if I treat every day? And we really do not have an answer to that question. Here is an example of that laser coverage. On your left is the HairMax laser band, and the Theradome device is on your right. You can see how the diodes are organized here. This is just an example of what patients can get. This is the Capitalist device. It looks like a cap. And these are all the diodes that are on there. So they put that on their head. And our question sometimes is, you know, if you have very thick hair or curly hair, does the light really get through? But those are still all unanswered questions. This is the Theradome device. This goes on the head. It looks like a football. And this is the inside of it, again, demonstrating all the lights. So in conclusion, low-level light therapy offers an alternative option for pattern hair loss. It also is a good option for people who want something natural and who don't want any oral medications or put things on their scalp, or perhaps even during pregnancy if there's a hair issue. There has been a rapid increase in market availability of these devices. We still don't fully understand them. We still can't answer the patient's question of which is the best, and further investigation is needed. So thank you very much, and again, thank you for the invitation to see your beautiful city. Thank you.